Can you see the screen?
Yes, ma'am.
Yes, very clear and wide.
So should I read it out for you?
Yeah, you can. You
Yeah,
just read
okay.
out questions and let the answers come in the chat box.
Okay. So differential cyanosis is defined as difference in oxygen saturation of at least 5% or a difference in partial pressure of oxygen of at least 20 millimeter of mercury between the arm, and that's the right arm, and the leg. If the upper extremity oxygen measurement is lower than the lower extremity oxygen measurement, so this is called a reverse differential cyanosis. And which of the following congenital heart disease most often associated with reverse differential cyanosis? Is it dextroposition of great arteries with coarctation of aorta or pulmonary hypertension, or Epstein anomaly of the tricuspid valve, or tetralogy of Fallot with absent pulmonary valve, or total anomalous pulmonary venous connection, or truncus arteriosus?
A, dextrotransposition of great arteries with coarctation of aorta or pulmonary hypertension.
Who's this?
Garima.
I can't see who's talking. Purvi?
Dextroposition
Yeah.
of great arteries with coarctation of aorta.
Why is it that? Can you answer? What happens in this?
Ma'am, pulmonary hypertension is associated with differential cyanosis, but due to dextroposition, the pulmonary arterial circulation, which normally the descending aorta's circulation, which is normally going to the lower limbs, it is dextroposed, like it's going to the upper limb, and it is opposite of the normal circulation. That's why there is the upper limb saturation is lower than the lower limb.
Yeah. So basically, the transposition of great arteries means the right side is connected to the aorta and the left side is connected to your pulmonary vessels, right? And so when this pulmonary hypertension or coarctation, it will be reverse will happen. So in the others, it won't be because those malconnections are not there. So the differential cyanosis, reverse differential cyanosis may happen, but it will not be a reverse one. Okay. Because if you do a heart screening test in the total anomalous pulmonary venous connection, you will have the saturation difference there, but it will not be reverse, right? Okay, the next question. A 1-hour-old term female is having a respiratory distress. She was born in meconium strain amniotic fluid. Her oxygen saturation is low and the saturation in the lower limb is 10% lower than the saturation measured in the right wrist. You suspect possible persistent pulmonary hypertension of the newborn. Which of the following statements correctly describe the pathophysiological nature of PPHN? So PPHN, high pulmonary vascular resistance, decreases the blood flow to the lungs, and there is a preferential blood flow to the systemic circulation, which is the path of least resistance. Or in PPHN, the oxygen saturation is likely to remain at a consistent stable level with a very little change. And C, in PPHN, there is an excess induction of endothelial nitric oxide synthase, leading to an abundance of nitric oxide in pulmonary vasculature. D, in PPHN, there will be excessive shunting of deoxygenated blood that flows from aorta to the pulmonary arteries. Or E, the foramen ovale must be closed for PPHN to have clinical manifestation in the newborn.
And A. First one.
Yeah. So it will be this because pulmonary vascular resistance is higher, so the blood flow to the lungs will be decreased. So that's how it would be. And it will be like not the nitric oxide actually is reduced. So that's the reason you are giving NO. which is a vasodilator, right? So it cannot be C. And it cannot be B because there is always a fluctuation of the oxygen saturation, and that's the main way how you pick it up, PPHN in your babies. And of course, it cannot be E. Foramen ovale must be closed for PPHN because you actually most of the time it will be open, and that's why you will have right to left shunt, and you will have issues because of the PPHN there. And so is the PDA sometimes, right? Next question. The term hypertension can be defined simply as an abnormally low blood pressure. However, the definition of hypertension in neonate is compounded by uncertainties in establishing the lower limit of normal blood pressure, below which treatment is required. Of the following, the most common approach to define a hypertension in neonate is based on what? Because it's the most debatable one. And so it's based on what? A, absolute threshold value of blood pressure, below which an adverse outcome is going to be happening likely. Or B, extrapolation of data for blood pressure values from healthy neonates and young children. C, level of blood pressure below which a disruption of important physiological variables is likely. D, a randomized controlled trials investigating the optimal threshold value of blood pressure for treatment. Or D, reference range of blood pressure values from a cohort of healthy neonates who have experienced no adverse outcomes.
Ma'am, C, level of blood pressure below which a disruption of important physiological variables is like.
No, it's like it has come out with a cohort of others. Someone else will say, because this is the most hypertension definition is the most controversial one, but it has come up with a reference range of blood pressure values from cohort of healthy neonates who have experienced no adverse outcomes. And then, so below that, when you say, that's how you have defined hypertension. And that's why each time when you say the blood pressure is low, doesn't mean that you might have some abnormalities or adverse effects going on. So it's a range. And that's why you don't act on each blood pressure, which is just lower the range, because you will have to see clinically how the baby is behaving. So it has come out with E. The answer is E. Okay. Is it clear?
Yes, ma'am.
Yeah. So the fourth, a term newborn has a cluster of blisters on the abdominal skin. The lesions are non-tender, filled with cloudy yellowish fluid and surrounded by a thin rim of erythema. The blisters rupture easily, leaving behind superficial glossy erosions with scaly crust. The newborn shows no signs of systemic illness. Of the following, which would be the most common cause of skin lesion in this newborn? Would it be the way I'm not showing you the picture, I'm just giving you the how the blisters would look like. So seeing that, where would you put this lesion? Bullous impetigo, cutaneous candidiasis, pseudomonal skin infection, staphylococcal scalded skin syndrome, and varicella zoster virus infection. Any answer? I can see the answers in the chat box though. So some of them have answered them correctly. It is a bullous impetigo, because in cutaneous candidiasis, you will see the target lesions, right? And pseudomonal skin infections will not be looking at like these blisters. They will be just blackish things. And staphylococcal scalded syndrome will be like a scalded. It's quite extensive, and they are the skin will be peeling off skin will be there. And varicella zoster virus infection, there will be not a superficial glossy erosion, then scaly crust will not be seen in these varicella zoster. So it is a bullous impetigo. So these are very common, and mostly, we get very much confused with the skin lesions. And so the differential we do can involve dermatologists, but we ourselves should be able to actually differentiate these skin lesions, which commonly occur in our newborns. And the treatment would be different for different skin lesions. Is it clear? Can I move to the second one, fifth one?
Yes, ma'am.
You are attending a delivery of a 25-week gestational age neonate. After birth, the umbilical cord is clamped after 60 seconds, and the neonate is placed on the radiant warmer. A plastic wrap is placed around the neonate. The neonate receives continuous positive airway pressure via mask and TPs, and the temperature is monitored in the delivery room and after arrival in the neonatal intensive care unit. Which of the following statement is regarding the thermal regulation in the preterm neonate is correct? The preterm neonate can maintain core temperature in only a narrow range of environmental temperatures. A preterm neonate has excessive brown adipose tissue, which leads to a higher metabolism and increasing shivering. A preterm neonate has a more subcutaneous fat tissue, which is inefficient in preserving heat. Preterm neonate have a overreactive sweat glands, leading to a higher degree of evaporative heat loss. The ratio of skin surface to body weight in preterm neonate is 10 times that of adults, leading to a greater likelihood of radiant heat loss.
E.
It's 10 times of adults.
E. Last option.
It's the A, because it cannot, mainly the preterm neonate can maintain a core temperature in only a normal range of environmental temperature. And that's why we have to be very careful on that when we keep the environmental temperature in extremes. So the ratio of skin surface to body weight in preterm neonate is not 10 times, it's much more higher than the adult. So the answer is A, not E. And of course, they have less brown adipose tissue, and they don't have a much subcutaneous fat glands, and they don't have overreactive sweat glands.
Is Dr. Monica still there?
I think, sir, ma'am had internet issues, I think. The OSCE was, the MCQ was going on, fifth MCQ.
I think we give her a minute or two, or then we can start with Dr. Pratima. So as Dr. Monica tries to get back onto the web, let me introduce the faculty for the day, Dr. Pratima Anand, young, dynamic from Safdarjung Hospital. Again, a passion for teaching, and that is one of the biggest reasons we requested her to be the faculty for the day. And I'm every day amazed at what we have got from our teachers. We are always willing to more than pass on to the new generation of neonatologists. I belong to the old. Pratima is still to the new generation of neonatologists, and they have so much of zeal to teach. I would say Monica also belongs to the new generation. The way she conducted the last session, and even today, the effort that has gone into making those MCQs is for everyone to see and to really emulate. Today we would have Dr. Pratima presenting in OSCE, which would be equally an amazing affair. I can assure you. I've gone through some of the questions, but then we do give creative liberty to the teachers to really go through the sessions in their own way, which actually helps students develop more skills and perhaps more confidence in facing some of those difficult situations once the actual exam comes in. I don't think Dr. Monica is able to join, and we would be happy to really let Dr. Pratima take over and have the presentation of the day, the case presentation, followed by if Dr. Monica joins, then we'll have those MCQs followed by the OSCE, or we can have the OSCE by Dr. Pratima. So over to you, Dr. Pratima.
Thank you, sir. Thank you for the generous introduction, sir. Yeah, Sayuri.
Yes, ma'am. Good evening, ma'am. Ma'am, I am presenting case of baby of XYZ born of non-consanguineous marriage to a 25-year-old.
Wait. Sayuri, wait, ma'am has joined in, no? So let us
Yes,
complete the OSCE.
Yes.
Ma'am, you can complete the MCQs, ma'am. We just thought we will have an introduction.
Monica, you need to unmute yourself. We can't hear you, Dr. Monica. We can't hear you, Dr. Monica.
Okay, now.
Now done. You're loud and clear. So you can share your screen again, and we can start from the 6th question.
She has disabled my screen sharing. She has to enable it again.
Yeah, please, Sarita ma'am, can you enable her screen?
Ma'am,
Yeah. Done. Okay.
Done. Okay. Done.
We were on the sixth question, right?
Yes, ma'am.
Yeah. So, could you hear my, or should I repeat it?
No, ma'am, we could hear the 5th only. It was stuck on 5th.
Okay, 6th then. The sensitivity of detecting white matter lesions depends largely on modality of imaging and timing of the study relative to the onset of injury. Of the following, recognition of the non-cystic white matter lesion is facilitated most by the technique of CT scan, cranial ultrasonography, diffusion weighted imaging, MR resonance imaging, MR resonance spectrography, or near infrared spectroscopy.
C, diffusion weighted MRI.
Yeah. So that's right, because you know that in the CT we will not be able to see some of these lesions, and in ultrasonography definitely beyond the ventricles you cannot see. MR resonance spectrography is also used to see these non-cystic white matter lesions, but sensitivity is much higher with the diffusion weighted MR resonance imaging, and near infrared spectroscopy is not meant for this. That's meant for what you had shown, those lactate and those ratios we can see in that. So the answer is right. Question number 7, a 12-hour-old term newborn has an episodic stiffening and posturing of the left leg that does not resolve with repositioning of the leg. These movements are sometimes associated with eye deviation and head turning and correlate with epileptiform rhythmic discharges on a EEG. Of the following, this neonatal seizure is most likely classified as what? Focal clonic, focal tonic, generalized tonic, myoclonic seizures, or subtle seizure?
Generalized tonic seizure.
So some of them have written correct answer that it is a focal tonic seizure,
Focal tonic.
because what has happened is not that, you know, the whole body is not got into stiffness. Only that leg is stiff, and that is sometimes associated with only eye deviation. So it is focal tonic seizure still. It is not generalized tonic seizure. And of course, clonic seizure is different, and myoclonic would be just twitching, and subtle seizures will be only deviation of the eyes. So this is not a generalized tonic, okay?
Yes.
Question number 8, a 30-week gestational age girl is delivered via cesarean to a woman who has had a premature rupture of membrane and received antenatal steroids. The neonate has respiratory distress and is placed on CPAP, starting in the delivery room itself. It is planned to provide surfactant via the Hobart method. Which of the following is true regarding the strategy of surfactant administration? This method is designed for neonate who are intubated in the delivery room and transferred to the neonatal intensive care unit while receiving positive pressure ventilation. The first 3 clinical trials to date have been stopped due to issues surrounding the safety of the catheter. See, one difference of this method from crib colon strategy is that the Hobart method does not require the use of McGill forceps due to the nature of the catheter. D, this method requires the use of synthetic surfactant due to compatibility issues with the catheter specific to the procedure. And E, to minimize the gastric aspiration, this method requires a short period of paralysis while surfactant is being administered. Yeah, Purvi, Garima. So some of the answers, like few have written correct, some of them have written wrong, but the answer is C. Because the difference between this and that is the McGill forceps is not used in that. And in this Cripps colon strategy, you use the McGill's forceps. Okay. You don't need a particular type of surfactant. You can use any of them in them. And when once you have intubated, there is no point using these methods. So it cannot be A. And the safety definitely is fine. So, and you don't do the paralysis because you want the baby to breathe, right?
Yes, ma'am.
Yeah. The 9th question, a 32-week gestational age newborn has a respiratory distress and chest x-ray is indicative of respiratory distress syndrome. You are considering the use of nasal intermittent positive pressure ventilation. Which of the following settings may be appropriate for initial management? So the respiratory rate of 40 per minute, the same peak inspiratory pressure noted when giving manual positive pressure ventilation, inspiratory time of 1 second, flow rate of 2 liters per minute, and positive end expiratory pressure of 4.
So 40 breaths per minute.
Huh? I can't hear you.
The rates of 40 breaths per minute.
Yeah. So that's the right answer because the others are all wrong. You will give a flow rate of much higher, at least 5 or more. And P, you will give more than 5. And then you will also see how much is required. Inspiratory time would definitely not be of 1 second, it will be different. And the PEEP, you will start with how much PEEP?
5.
Yeah.
Mm.
And PIP?
15, 16.
Yeah, and then you will look at the how much is the chest
Chest
rise and you
rise.
will change, right? Okay, the last question. Inhaled nitric oxide may have a role in prevention or amelioration of BPD in preterm units. Which of the following statements regarding mechanism of potentially favorable effect of nitric oxide in lung is false? The nitric oxide decrease, there is a decrease in pulmonary vascular resistance, enhancement of alveolar development, inhibition of lung neutrophil accumulation, protection against surfactant protein dysfunction, increase in vascular remodeling.
E, ma'am. Last, increase in vascular remodeling.
Good. So the rest of the things are what the nitric oxide does, and it helps the baby's lung to thing. But if you will increase the vascular remodeling, it's going to be a opposite effect,
Worsening.
right? Yeah, it might be worsening. Good. So thank you, Purvi and Garima.
Thank you, ma'am.
It was nice interacting with you, and all the best for your finals, right?
Thanks.
Thank you.
Thank you, Monica, for those very wonderful MCQs. It takes a lot of effort to make such good MCQs, and thanks for taking out that effort and making the MCQs more clinical MCQs rather than more theoretical MCQs. Thanks a lot. We'll keep
Thank
you
you.
busy in the next session of FEAT also. I think people have enjoyed it, and so that means you have to work even more. And I know you don't mind working that much.
Thank you. Thank you.
Thank
It
you.
was nice
Thank you,
interacting.
Dr.
Thank you. I may leave.